Thank
It's
you,
up to
Emek,
you.
very, very much. Thank you very much for your outstanding presentation. It's very
Thank you.
excited to hear the findings of the study. And I would just like to ask your personal approach as a physician from the experience. So, you know, and you have black on white data telling you that, okay, so urticaria tends to improve during the
Mhm.
pregnancy. What is your approach when the patient comes to you and says, okay, so I would like to start planning my family and
Mhm.
I'm a little bit more afraid on taking medication. So what would be your approach? Would you suggest to stay on the same dosage of medication? Would you suggest to uh, as a prophylactic dosage to for short term for the first time trimester to
Mhm.
increase the dosage? What is your approach?
Thank you for this wonderful question. So, of course, what we are doing in the normal setting, it depends on, of course, the patient's disease activity. If the patient is fine with standard doses of antihistamines, then I switch to usually cetirizine or loratadine. And of course, if so in Turkey, it was usually like that. Patients come and say, "Oh, I'm pregnant." But maybe in other conditions, some of the minority of the patients were asking me, "I will conceive. So what shall I do?" If the patient is very, very anxious about using treatment during pregnancy, then they can take their antihistamines till they conceive because antihistamines will be out of their blood in maximum 24 hours. So they can stop after becoming pregnant. But for omalizumab, it's different because it's a big molecule that stays in the body for so its half-life is 26 days, but we should consider that it can still stay in the blood up to 5 months. So if the patient is considering conceiving, then we need to, and is very, very anxious about using any medication, especially omalizumab medication, then we should tell them that if you are that much anxious, then we should stop it 5 months before getting pregnant. So this is, we need to communicate with the patients. But we stop the treatment, and if the patient is getting worse and worse, the stress of the disease
Of
causes
course.
a lot of disturbance and stress on the body. So that I think conceiving would also be difficult for these patients because
Of
they will
course.
have sexual difficulties, mental problems. So we need to always communicate these with the patients. And so it depends on the disease activity, I would say. But I switch to cetirizine. I do not up dose to 4 folds. I up dose to 2 folds. If the patient doesn't want to use omalizumab, sometimes I give very small doses of steroids for very short terms just to relieve the patient. But generally, my experience is that urticaria really gets better during pregnancy. But I had patients who had to use omalizumab. And one thing I want to say about omalizumab is that it's safe to use during the first trimester because it passes after the 26th week from the placenta. So if the patient is very cautious, then they can take it on in the first trimester or at the beginning of second trimester, but then quit till birth. Maybe it's another option that they can use.
Okay. Good. So we actually had this similar question. So would you consider and begin omalizumab during the pregnancy? So if that is related with exacerbation, I do
Yes,
believe up to
it's
the third
B.
trimester.
Category B, and it has been reported. And there is a 26 patient case series in urticaria and pregnancy. So they also found that there are no worse outcomes with pregnancy. And there is a big registry on asthma patients. They also saw that there are no big problems when compared to patients who didn't take omalizumab treatment. So I think it's a safe treatment and it should be given when the patient really needs it.
Good. Thank you. So we have a lot of questions that we still need to cover, but I would now like to move forward a little bit with Marlene, and I would gladly ask you to share your knowledge with us.
Thank you so much. And thank you, Emek. It was a beautiful presentation. And I'm so happy to see that there's actually a lot of overlap also with our clinical experience. So I'm Marlene Lee, I'm a gynecologist, and I'm so happy to talk a little bit about the gynecological perspective on pregnancy and chronic conditions in pregnancy and drug use in pregnancy. Okay, to start off, I would like to say in general, as Emek sort of closed it with, is always when considering medication in pregnancy, it's always really important to take into consideration, first of all, the chronic condition that's underlying, the severity of the condition and the symptoms and how much they affect your everyday life. So it's a very personalized decision, and it's really, really important to make this decision in an interactive manner. So really consult your healthcare professionals and be participatory in this decision-making process. It's also very important to really bear in mind that every health journey is different, and particularly during pregnancy, every pregnancy is different. And I'm going to share a bit about the general, what generally occurs during pregnancy, but that does not mean that this is your journey. So it's very different. And so it's super, super important to take a very individualized and personalized approach, particularly during pregnancy. And just to show some data, so pregnant women are exposed to an average of 2.6 medications during pregnancy. And about 90% of pregnant women are exposed to at least one medication, and 80% during the first trimester. The data on medication that we currently have for use in pregnancy comes mostly from observational trials, and I will go into that a bit later. And many of the women who require medications for the treatment require this due to conditions that are present prior to pregnancy and do not generally occur during pregnancy. And as I said, deciding on starting, stopping, or changing medication needs to be approached on an individual basis, taking into considerations all of the things that I mentioned. And participatory decision making is crucial. So to understand sort of the effects of medication during pregnancy a bit better, I found this graph which basically shows you what happens during the fertilization, which is when sperm sort of enters an egg, the baby, this is called fertilization. And then very quickly, after a couple of days, the cells really split. And this is a process where a lot happens. And after a couple of days, the cells sort of implant into the uterus, and then they become an embryo. And really, unfortunately, you cannot see it so well here, but here is within the first 3 to 8 weeks is when most of the organs of a fetus develop. So this is a really crucial period of time, and this is where medication might affect a baby most. So this is why we always look at medication during the first trimester, second and third trimester. Okay, so to also understand what medication does in a pregnant woman, it's important to look at the physiological changes that occur in pregnancy. So we start off with an increase in cardiac output, which increases in about 30 to 40%. It begins in early pregnancy and plateaus in the second trimester. We then have an increase in blood flow to accommodate this increased cardiac output. We have an increase in water and sodium in the body. And this also has an effect, of course, on drugs and the bioavailability, so how much of the drug is actually available. So this is really important to take into consideration when prescribing medication in pregnancy, that the dosage might be different. Also, the metabolism and the clearance of medication is different due to hormonal alterations in drug metabolizing enzymes during the pregnancy, but also due to an increase in the renal blood flow, which sort of clears the drugs much faster. So these are things that one needs to consider when prescribing medication in pregnancy. And as Emek also said, the role of the placenta is really important in sort of the passing from drugs to a baby. So back in the day, we actually thought that the placenta was a complete barrier and it was protecting the baby completely from all kinds of medication. But as some of you might know, in the late 50s and early 60s, there was an incident with a medication called thalidomide, which was prescribed for mothers for morning sickness, and it was prescribed to them without being tested on pregnant women beforehand. And actually, it then caused a lot of malformations on the babies and also a couple of deaths on babies. And this is really when we became very aware of the function of the placenta, and that it does not protect the baby fully, but actually that most of the medication passes through the placenta and comes to the fetus. And of course, this depends on also the size of the molecules of the drugs, but nearly all medication will be present in the fetus to some degree. And the placenta is a vital organ because the main role of the placenta is, of course, the transportation of oxygen and nutrients from the mother to the fetus, but also, you know, also the other way, so all the excretion from the fetus to the mother, basically. So this helps the placenta. Emek also already talked about the categories that are by the Food and Drug Administration, so the FDA pregnancy categories. We always look at those when we when we want to know if a drug or a medication is safe to prescribe. This is the international one, so the FDA. We have categories A, B, C, and D. A meaning it's a very safe drug that where controlled clinical trials have shown no risk, and also no risk in later trimesters. Category B is where animal reproduction studies show no risk, and and so it's quite safe to give. Category C is where caution is advised because there has been some risks in animal studies, but the benefits may outweigh the risks. Category D is where there is evidence to potential risk to a human fetus, but the benefits may outweigh the risks in very serious conditions. And that's why I'm saying it's very important to really take into consideration the underlying condition, because sometimes just having a condition and having it flare up can also really determine the course of a pregnancy. So it's very individualized. And category X is an absolute no-no. So these are the drugs we should not prescribe. And as I practice in Germany, I've also brought to you the embryo tox categories. They're similar to the FDA categories, and in most cases, they really overlap with their recommendations. So it's the green is a drug of choice for specific treatment or indication for which we have extensive experience in pregnancy. The red category is a drug with confirmed risk to the fetus, and the gray one is a category for which more or less extensive experience in pregnancy has been gathered, and there's no significant risk, and there needs to be an individual risk-benefit assessment before use during pregnancy. Just a couple of points for urticaria in pregnancy, but Emek already covered that a lot. So there was not a lot of data on urticaria in pregnancy, but from the data that I found, it does not seem to affect fertility. So there's no effect on getting pregnant. The chronic condition itself does not affect the baby. There are no changes in general to the onset or the progress of labor or delivery, and there's no impact on a normal delivery. So the birth mode, vaginal versus cesarean, so it does not impact that. And in general, what I found also is that it does not seem to worsen during pregnancy, but tends to get better, although, of course, this is very individual. The treatment algorithm as well from the guidelines that you've already showed is to start off with antihistamines, then go on to omalizumab, and then go on to cyclosporin. And I brought to you now the drug categories and what we recommend to do before planning a pregnancy or while being pregnant. Antihistamines is category B and green. we have a lot of data and evidence that antihistamines during pregnancy and also during breastfeeding is completely safe. So the preferred substances are actually loratadine, cetirizine, and levocetirizine. So these are all second-generation antihistamines, although you can also use first-generation antihistamines, but due to the drowsiness they may cause, we do tend to favor the second generation. And when I say experience level is very high, as I explained earlier, due to this thalidomide scandal back in the 60s, there is virtually no studies that are conducted on pregnant ladies, but there's a lot of observational data. So people who had to take the drug were observed and all the information was gathered. And loratadine seems to be the best studied antihistamine and seems to be like the safest. We have data of over 5,000 women who have been prospectively followed, and there was absolutely no risk, increased risk of malformation or anything else in the pregnancy. And also for breastfeeding mothers, it was absolutely safe to take. Omalizumab, Emma already mentioned as well. So the experience level for use in pregnancy is about medium because we just do not have as much data on the use of omalizumab during pregnancy. There was actually a trial conducted by the manufacturer of 230 pregnant women, and there's several case reports. And so what it seems to be is that in the first trimester, there's no risk of increased malformations. If we remember, in the first trimester, most of the organs form, so this is a crucial period. And in the second and third trimester and during birth, because the molecule is a bit bigger, it passes through the placenta more, so there's more of it available to the fetus, and you can actually detect that. And there was a slightly higher risk of preterm birth, as you already also mentioned. However, it wasn't clear whether it was just caused because of the drug or because women who were taking omalizumab for some disease actually had higher risk in preterm birth anyway, due to the underlying condition and the course of pregnancy. So it's not quite clear there yet. And also, I mean, I think you showed 9%, and that's about the average preterm birth rate, also in Germany and mostly internationally, which is about 6 to 12%. So what we recommend when you plan a pregnancy under therapy, that it is possible to use it if other safer alternatives have failed, because an effective disease control is an important prerequisite for an undisturbed pregnancy. And as we mentioned a lot, it requires careful individual risk-benefit assessment. So consequences after use in pregnancy. In Germany, we do recommend an additional ultrasound examination after exposure during the first trimester. And if you take it for a continuous amount of time, then we do recommend also regular sonographic monitoring of the fetus and the growth of the fetus. And breastfeeding, so in the data we have to date, there were no side effects in fully breastfed infants, and it seems to be acceptable. Going on to cyclosporin, this is a drug that is usually used for the prevention of rejecting an organ transplant, but also for the treatment of some immune-mediated chronic inflammatory diseases. There is actually a very high experience level for this drug in pregnancy. There's data of more than 3,000 exposed ladies who were pregnant, and it showed no evidence of teratogenicity. So that means that it's toxic to the baby or pregnancy. And there were no risks for malformations or spontaneous miscarriages. In the second and third trimester, there has been a higher risk for intrauterine growth restriction and low birth weight, so basically smaller babies, and a higher rate of preterm birth and a higher rate of preeclampsia. Now, it's really, really important to note when you look at this data is that there was a clear difference between women with organ transplant who took cyclosporin, because it's usually women who have a very severe underlying chronic condition, versus women with other conditions who use cyclosporin. So it's really important to bear this in mind, because most likely just cyclosporin on its own will not cause these effects, but usually it's a game of the two, the chronic condition and the drug. So what we recommend is that it can be used only if the benefits outweigh the risk. And you can really prescribe it at any point in pregnancy. And someone who's very stable on cyclosporin, for example, after an organ transplantation, shouldn't be switched because of the pregnancy. It's really important to monitor the levels of the drug during the course of pregnancy. It's important to monitor the baby and the fetal growth and to monitor the blood pressure. In breastfeeding, there is different recommendations from the German guidelines and the American ones. So in Germany, we actually say that patients who are stable on cyclosporin shouldn't be switched just because of breastfeeding. In America, so the American Academy of Pediatrics does actually recommend to abstain from breastfeeding. But so far, there have not been any reports of adverse effects on infant growth, development, or kidney function for children who were breastfed while their mothers were on this drug. And sort of to finish it, I also included prednisone or prednisolone, which are the two types of cortisones that should be preferably used during pregnancy. And you also said that it's not advisable to use it for a longer term for the treatment of urticaria. It's also not advised to use long-term steroids in pregnancy. So there's a bit of a not quite conclusive data on the cleft lip, which you also showed that there was one patient, but who didn't actually take steroids. So yeah, it is possible, but we're still not quite sure. And the risk for the development of cleft lip is highest between 8 and 11 weeks of pregnancy, so in the early stages. It is, however, safe to take it if you really need to take it. And it's generally okay to take it for smaller amounts of time. And the local application of steroids is usually totally okay. So what we recommend is if it needs to be done, it can be done, and it can be done during all stages, but it's really dependent on the dose. So higher dosage for very longer times of periods, of course, have more effects on the baby versus short-term corticosteroids. And the consequences, so we do recommend fetal growth monitoring, and during breastfeeding, we do recommend that if it's necessary, one should prescribe the lowest dose possible, and you should avoid breastfeeding for 4 hours after intake of prednisone. So to conclude, urticaria does not seem to have a negative effect on pregnancy and birth outcomes. Most of the medication used for treating urticaria are safe and can be administered during pregnancy and during breastfeeding. And just be aware, because there's some symptoms that, of course, present differently in pregnancy versus non-pregnancy. And most importantly, a personalized approach taking risk-benefit analysis into consideration together with the healthcare professionals, but also you and your symptoms, is the most essential. I've also brought you a couple of helpful links if you're unsure of whether you can take a medication or not. So there's the FDA website, which contains information about the pregnancy medication you can take during pregnancy. There's Mother to Baby, which have fact sheets, but you can also contact them and ask for help by phone chat or email. And for the German speakers, there is Embryo Talks, which also provides information in German, and you can also do individual consultations there if you're unsure. And that's it. Thank you very much.